This short video will help identify specific topics to focus on when reading the assigned articles dealing with ethical issues with children as a vulnerable population. Children are considered a vulnerable population, and as such, they are accorded special considerations and special legal protections. The nurse is required ethically to continuously advocate for the child as an individual and as an integral member of the family. The 3 required articles for this module each deal with a different aspect of ethical considerations with children. This video deals only with the Helen Harrison article entitled "The Offer They Can't Refuse: Parents and Perinatal Treatment Decisions." Make certain that you review the Part 2 video that discusses the Pate article on assent and dissent and the Tillett article that deals with the adolescent and informed consent. But at the conclusion of this video, it is hoped that you will understand frequently associated dilemmas with the very premature infant in a neonatal intensive care setting and identify ethical principles to guide decision making in those situations. Think for a moment what the title, "The Offer They Can't Refuse," might mean. Now, Helen Harrison is not a healthcare provider. She is a mother and a writer who has written to extensively advocate for parents of very premature children, to remind healthcare providers of the stressful nature of making decisions with this vulnerable population. And she actually terms this dilemma the offer they, meaning parents of premature infants, can't refuse. She also introduces the term the gray zone. It is important that you understand these 2 phrases and the ethical dilemmas that result from these concepts. So, thinking about the title, "The Offer They Can't Refuse," reflect that if you or someone in your family had a child born about 6 or 8 weeks early, the infant is very immature, there's a great deal of uncertainty if the child will survive, or if the child does survive, what the complications might be. But the offer that the doctors and healthcare team make is, we can keep your infant alive with extreme measures that may be required for 4 to 6 months without any assurance that the baby will be healthy or functional or will even live. The offer they can't refuse is that offer to keep the very premature infant alive regardless of the money or time or energy or anticipated outcome. And parents are under extreme pressure to say, yes, of course, do whatever is necessary, even though the outcome will require extreme challenges and long-term care involvement. The offer that they cannot refuse happens because the very premature child is born within what is informally called the gray zone. The gray zone is that time during pregnancy around 26 weeks or so. Remember that a pregnancy is about 40 weeks. So the gray zone is a very gray or nebulous time during which the infant is about half developed in terms of metabolic and neurological capacity. And sometimes we can support them using extreme technology through all of the complications that will develop as a result of this immaturity, to allow development and maturation to about 40 weeks, and sometimes we cannot support infants born in this gray zone. This is not to imply that all premature infants have long-term neurological problems or other health issues. And I've included information on one website that advocates for premature infants and offers parents tips on dealing with premature infants. This web link is for your future review and not for the exam. But there are many ethical dilemmas that are present in the care of a very premature infant, and Harrison identifies two key ethical principles that can be used to guide decision making in this area. The first principle deals with beneficence, and it deals with considerations of beneficence for the infant and the family. Is it beneficial to save a child at 26 weeks who may easily have resultant brain damage, developmental delays, and prolonged respiratory complications? Many premature infants do have residual neurological delays, they have chronic breathing problems. Is it beneficent? Is it most beneficial to save a child who, in essence, we know will have these complications as a result of prematurity? And Harrison is encouraging healthcare providers to ask, is it really beneficial in this instance? The second ethical principle that Harrison encourages providers to consider is that of maleficence. It is critical to consider ways in which the infant and family may actually be harmed or burdened in an unacceptable proportionate manner by continuing treatment or stopping treatment once it has been begun for children who are born in this gray area. Harrison encourages healthcare providers to consider other ethical considerations, that of justice, to truly say, should healthcare resources that are so scarce be used in these cases? These children are frequently in the neonatal intensive care unit for months, 3, 4, 5, 6 months, with each day costing more than $1,000 a day. Is that effective utilization of scarce healthcare resources? The second consideration is Harrison's pleads for healthcare providers to think through who should decide whether treatment should be continued, because physicians will frequently recommend continuing treatment. This is what healthcare providers do. The dilemma results when there must be a reckoning of how long do we continue this, and who has the right and the responsibility to say how long this should be continued and whether treatment should be continued. Another ethical consideration is Harrison's pleas for providers to consider the common good. What are the benefits and the burdens on the common good when we do support and sustain children who are born in this gray zone? As a society, we advocate spending millions of dollars and offer great support and resources for families when children do spend months in the neonatal intensive care unit. However, when they are discharged, families find that there are very limited support and few resources to sustain them in their parenting. Harrison is asking healthcare providers to consider how does that affect the common good of the family, the extended family, the neighborhood, and all of the community. But Harrison is most passionate in her article about turf wars that providers frequently engage in when caring for very premature infants. It's important for you as a future nurse to realize that the physical environment in which healthcare discussions are made influence the discussion a great deal. Think of the difference in the discussion if you and a faculty member talk about how is your semester going in that faculty member's office, or if you talk about how is your semester going when you see each other in passing on the mall or in the Texas Union. It's the same way in the hospital. If a physician asks a family, "Do you want me to continue working to keep your baby alive?" when they are all looking at the baby in the neonatal intensive care unit with the tubes and the monitors alerting and all of the hurry, the parents are pressured to say, "Of course, yes, do anything, do everything." That answer may be different if a chaplain or a social worker asks that same question when the entire family, the other children, the grandparents, the siblings are present in a small, comfortable conference room or lounge away from the beeping machines or the smell of alcohol. So the turf wars occur when providers want to talk on our own turf rather than on the family's turf. And Harrison is simply encouraging healthcare providers that we have an obligation to talk on the parents' turf and to look at situations from their perspective. So in view of these turf wars and ethical dilemmas, Harrison offers recommendations to help parents enable them to refuse the offer if that is deemed most beneficent to the family. And Harrison offers two recommendations. The first recommendation is that as a part of prenatal care and counseling, we should include discussions that allow parents to develop directives or understandings about a proposed plan in the event of a premature birth. This would be helpful for all pregnant women to consider, but would be especially helpful in a pregnancy in which there have been previous preterm births or where there are known maternal or fetal complications. And this is similar to advanced directives in end-of-life situations we've discussed earlier this semester. It is better to have thought about and thought through possibilities and then share those preferences with someone else than to have to make an immediate, in-the-moment decision about such a critical life event. The second recommendation that Harrison offers is to establish mechanisms for parents to take premature babies home for palliative or supportive care if that's what the family wants. Frequently, very premature infants who we know will not survive are kept in the hospital even through the dying phase. And Harrison encourages providers to allow families to take the infant home to die in a similar manner to the allow natural death that we discussed earlier. However, this needs to be an interdisciplinary plan that supports the family during this very difficult situation. Remember that this article was written by a mother who was writing to pediatricians in their professional journal, advocating for children and families of very premature infants. It is helpful that we always listen to the people most affected by our decisions, and Helen Harrison has written extensively to advocate for healthcare providers to think about implications of our actions and to involve the family in all aspects of planning care, that we talk with them on their turf and strive to understand their perspective. This completes the discussion of the Helen Harrison article on the offer they cannot refuse.